going to go live, yeah. Hello, everyone, and welcome back to the Oral and Maxillofacial Surgery webinar series. My name is Omar Saleh, and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today for the fourth session of this series. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS. IADS is the largest global organization representing dental students worldwide, connecting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. This webinar series is organized under the SCORE Office of IADS. SCORE stands for the Standing Committee on Research and Education, and it focuses on research, education, and international collaboration. Through SCORE initiatives, students have the opportunity to engage with experts, participate in global projects, and gain valuable learning experiences. We hope you will find today's session insightful and beneficial. It's a great pleasure to welcome Dr. Bruno with us today, and we will sincerely thank him for sharing his expertise with us today. To introduce our speaker and guide us through the session, I would like to hand over to my colleague Adham.
Hello, everyone. Today's topic is partial root retention techniques in the biodigital era of implantology from biology to digital precision, presented by Dr. Bruno Wenhcke from Guatemala. His biography is Dr. Bruno Manuel Wenhcke Azordia is a board-certified oral and maxillofacial surgeon accredited by the Latin American Board of Oral and Maxillofacial Surgery and Traumatology. He holds a master's degree in oral implantology from the University of Valencia and has completed fellowships in dental implants from New York University and digital dentistry from University of South Carolina. He is an international lecturer and member of the MIS Dent Supply Implants Expert Group with a clinical focus on biologically driven and digitally blend implant dentistry. He is also actively involved in cleft lip and palate surgery as a cleft surgeon with Tests Unlimited in Antigua, Guatemala. Dr. Wenhcke currently serves as professor of the Oral and Maxillofacial Surgery postgraduate program at Universidad de San Carlos de Guatemala. The floor is all yours now, Dr. Bruno.
Thank you so much for the kind presentation. I'm so happy to present today with you. It's always a pleasure. And I will start just connecting my device. Just 1 minute, please. Okay, let's start like this. So the theme that I choose from presenting today is partial root retention techniques. I'm from Guatemala. This is my city, Antigua, Guatemala. You are very welcome if you want to come someday. We have a very good local food, and also I can see some hospitals or surgeries for you. Most of the time, I'm doing cleft surgeries like this, and also doing implant dentistry. That is the theme that I chose to present for you today. So let's start discuss about biology, what happened after dental extraction. As you can notice in the left side, there is a microphotography of the buccal bone, especially the cervical area. And you can notice, just one question, do you see these pictures? So as you can notice, there is a very small part of the buccal bone, and you can notice the periodontal ligament. The buccal bone is really very small, and its vascularization comes from the bonded bone, from the periodontal ligament, and also from the periosteum. Just imagine if you remove one part of this vascularization, you will expect some kind of problems because it's very thin. Most of the time, it's less than 1 millimeter. So it's important to preserve. It's important that we try to be, as most of the time, traumatic when we do dental extraction. In the next picture, you can show, or you can watch 2 weeks after dental extraction. There is a bonded bone. After 8 weeks, even this study was in dogs, you can notice that the buccal aspect is the one that get more resolved with time. This is post 8 weeks. You can also notice some close of the alveolus. We know that if we preserve, we know that if we use some kind of graft, we will contrarrest, or we're gonna expect less bone resorption, like in this study with xenograft. And also we know that if we do implant surgery, we will not compensate. We will expect bone loss if we don't take in account that we need to regenerate or preserve the buccal aspect. So this is a very important study from Vivian Chaput. You can notice that when we have a thin buccal bone, less than 1 millimeter, maybe you're gonna expect more than 92% of loss of bone. The study told about 7.5 millimeters. And what is important to mention in the other side of the coin is that when you have a very thick buccal bone, we only expect 9% of bone loss, especially in the vertical area, just 1.1 millimeter. So with that in mind, we know that the buccal aspect is very thin, it's very friable. So in this study of Mariano Sanz, we noticed that 90% of the cases are less than 1 millimeter buccal width. So now let's discuss about conical connection and platform switching. Platform switching was described by Lazara. He used a small abutment, and he moved the connection of the abutment inward from the marginal bone, from the crestal bone. And with that in mind, he noticed that he expect bone ingrowth of the platform of the dental implant. And you can notice in the picture in the right side, the abutment is not straight. It's a small diameter than the implant. So when you look at the X-ray, talking about connections, in the left side, parallel walls is internal connection with hexagonal, and in the right side with divergent walls, it's maybe conical connection or more stable connection. This is more stable connection, the right side, and you can notice that in the X-ray when you're trying to identify what kind of implant are you using. I also want to show you what are the difference between a natural tooth and a dental implant. On the left side, we have still periodontal ligament, we have irrigation from the buccal bone, and also from the periosteum. And then on the other side, we have less vascularization, we don't have periodontal ligament, we have less fibroblast, it's more like a scar tissue. And the right side, we're gonna create that tissue, and it depends about the prosthetic connection, the depth of the implant that we choose, and how we manage the surgery and the prosthetic phase. So how is the depth that we're gonna insert our implant? In the left side, 1 millimeter, we need to go very down, at least 4 millimeters below the gingival margin. But if we have a good quantity of soft tissue, we can go transcrestal, we can insert our implant at the level of the bone. And how can we manage the left side? We can convert this thin phenotype in a thick phenotype with soft tissue graft, and we can do in the first stage or at the second stage. We can notice in this picture. This is the soft tissue graft. When we open our implants, it's the second stage, and even we perform sometimes soft tissue grafting in the beginning, but we will need to make some modification at second stage. Several authors have described how we can manage our emergence profile, not only in the anterior zone, also in the posterior zone. So Dr. Gomez Meda in 2021 described 3 zones. The sulcular epithelium, 1 millimeter below the gingival margin. We know that this is gonna be very similar like the contralateral tooth, or similar or exactly the same before we extract the tooth. It's just 1 millimeter below the gingival margin. Then the junctional epithelium is the one that is gonna be with a strong adhesion. We need to grow a lot of tissue so we can seal this face, and then the connective tissue. The size of this connective tissue, it will depend on the depth that we insert our implant. But we have to take in account that it's not only a vertical dimension, it's also angulate dimension. And this is the reason that we need to insert or use slim abutments, at least of 2 millimeters, and try to make an S so we have soft tissue ingrowth in this area to gain more stability of our emergence profile. And also it's important to mention the angulation, our abutment, as this study described by Dr. Nicholas Matthews, that is very important that we stay below 30 degrees in our emergence profile, as we can notice here. Because if we choose a tie base lower than 1 millimeter, very wide, or we chose a custom abutment very wide, and we don't insert our implant very depth, we will still have problems like we can notice in the picture. So remember, at least 4 or 5 millimeters depth below the gingival margin so we can manage a very good emergence profile. Slim abutment, concave abutments, or slim abutments, less diameter from our implant, and try to be away from these 30 degrees so we not push the bone, so we not push the soft tissue. And it's not only in the buccal and palatal or lingual aspect, it's also, we need to make sure that we have the same in the mesial and distal aspect. It's three-dimensional that we notice to do that. So this is an immediate molar. We only take 3 appointments to do this. You can notice the several zones described by several authors, and also the first that described this was Dr. Su with the group of Dr. Oscar Gonzalez and Dr. Ernesto Lid, and you can notice the critical contour and the subcritical contour described in 2010. So we do an immediate implant, we do a soft tissue graft in the same appointment, and you can notice a very good result, very stable results, even that we are working with a tie base. So after the second stage, after 4 months, we can take the final expression. This is a scan post that reproduces the position of the implant, final delivery of the crown, and you can notice a good papillae, a good gingival margin, a very strong tissue attached to the crown. There is a very good, a beautiful article by Dr. Jonathan Misch that describes what are the importance of doing the PROS concept. And it talks about using platform switching. Remember, Dr. Lazara described small abutments to move the connection inward. Also about the restorative abutment design, it's important that we have a slim abutment, at least 2 millimeter, and also an optimal internal collection, taper, conical or Morse, and the most important, the position of the implant according to the soft tissue that our patient has. So let's discuss immediate implants in the aesthetic zone. We have several times that we can insert our implants. We are gonna talk today about type 1. So extracting the tooth and inserting our implant. And we can go guide surgery or using another techniques like drilling through the root that we're gonna mention in the continuous pictures. So Dr. Nicholas Elian talked about 3 types of alveolus. Type number 1, the ideal, when we have enough bone and enough soft tissue. Type number 2, it's like red because we don't have bone here, but we still have soft tissue. And if we insert a dental implant, maybe 3 or 4 months later, we're going to have a recession. So it's always important to take dental tomography, CBCT, so we know what we are doing and what kind of alveolus or what kind of socket do we have. And number 3 is obviously that we need to regenerate before the surgery. But it's also important to mention the study of Dr. Kang in 2011. He described 4 types. The number 1, the one that has a lot of bone in the palatal aspect that you can notice here, and also the type 4. It's important that we know that in the type 4, we have at least 2/3 of the root attached to the buccal aspect or the palatal aspect. It will be very risky. It will be very difficult to do immediate implant. Even if we go for immediate implant, we need to compensate that resorption because the root is attached in both aspects. So you are the next gen, but even that you are learning, you need how to do freehand dental implants. And in this image, you can notice an alveolus. So when we have this kind of socket, we know that when we make dental implant surgery, we need to go for a prosthetic-driven dental implant surgery. So it's important to insert our implant in the palatal aspect most of the time. At the beginning, we need a very sharp drill. It's very difficult because it's going to move to the air. It's going to move to the buccal space, that is the empty space. After that, you also have your start guide when you go for freehand. Then, depend on the brand of the implant that you are using, it's going to be a bore like 1.6 between 2 millimeters. And you have to enter like in the buccal aspect. Then when you are in the hole that you make with the initial drill, then move in the vertical aspect like this. And the continuous drilling, it's going to be the same, entering a buccal aspect and then go vertical. And remember studies like Botticelli that we don't need to insert a very wide implant to replace all the alveolus, like about 4 or 5 millimeters, because we always need to leave a gap and also be at least 3 or 4 millimeters below the apical. But it depends of all of the digital workflow, all the planification that we do before the surgery. Even if we are not doing guide surgery, we need a CBCT to plan our dental implant surgery. And remember that this is going to be replace this air with bone, or at least that we're going to expect. We're going to expect bone in the buccal area between the socket and the implant, above the implant, and also the soft tissue close. Remember the studies from Araujo. 8 months later, we have gain of soft tissue above this socket. So let's talk about the socket shield technique. The socket shield technique was described by Dr. Markus Hursler in 2010. It was a proof of concept. He described leave a partial fragment of the root in the buccal aspect with very good results. He also do histology. As you can notice, this was his first patient with an excellent result and also with beagle dogs. So these are the kits. I have tried most of them, but believe me, you don't need a very expensive kit. You only need a special board to section the root and then to modify the individualized custom healing abutment. As you can notice, the kit from Dr. Hursler is very small, only 5 bars. This is very special boards for the individualized healing abutment when you don't have primary stability. Even you don't have primary stability, you will need to preserve the soft tissue with individualized healing abutment. This is also very interesting books like the article described by Dr. Howie Glutman and Jonathan DeToot that we need an S space and also maybe made some kind of chamfer when we do the socket shield technique. And it's important, the prosthetic part described by Dr. Thomas Linkivision. This is my old case. It has more than 9 or 10 years from now. This is the control, 10 years post-op. As you can notice that we use a tie base. You can notice the root fragment in the buccal aspect with very, very good result. In that case, I don't use any kind of soft tissue graft. I don't use any kind of bone graft, and I still have a very good, adequate gingival margin, adequate contour, similar to the contralateral tools. So this is a very old case. We still having a tie base there with very good results. And the control CVCT, you can notice that we have a very good preservation of the bone. So I want to show you this video of the socket shield technique. First of all, you need to remove the crown, the coronate. After that, remove everything, remove the gutta-percha, remove any kind of material, restorative material. Then in this case, you use guide, drill into the root. Remember that you will insert your implant like you are doing immediate implant. After that, you have all the guide. Remember that it's gonna be in the palatal aspect. And then we're gonna section mesial and distal our root. Always try to use loops, always try to use a very good lightening, very good magnification. Be patient with, sorry, I will come back. Be patient with the extraction. We don't have to rush, we have to take our time. The mesial distal with loops and very good illumination, very good light. We can see the apical part. We can use micro luxators to remove the palatal fragment and then reduce the buccal part of the root 1.5 millimeters, remove the apical part, and reduce the palatal or the buccal fragment at the bone level. Then clean the alveolus, insert the implant. If we have primary stability, we can do immediate provisionalization. If not, we're gonna do an individualized healing abutment, as you can show in the video. We're gonna use a provisional restoration, then use an isolation, and then use flowable resin. Then we do extraoral. Now we use the board that I showed you at the beginning to make this concave shape, to make this S shape, so we can expect soft tissue in ground all around the connective tissue, all around the junctional epithelium. Even that we are not delivering an immediate provisionalization, always do an individualized custom healing abutment. And leave it at the level of the gingival margin. And then we can use an Essex, a flipper, or a removable. Now let's see a case of a soccer player with a root fracture. He wants to make everything in the same appointment. So we do a DSD, then take our dental tomography. We can notice a dental crown fracture. So we decide to go freehand because we don't have time with doing guide. This is how we choose our diameter, our implants. Most of the time in central insertion, I try to go for the standard diameter. In first molars, we try to go always for wide implant diameter. So then we use one-time abutment and use the same tube of the patient for provisional out of occlusion. This is immediate after the surgery, one-time abutment, 4 millimeters below the gingival margin, and this is the immediate X-ray. You can notice the fragment of the root, you can notice the one-time abutment in position. Then after 4 months, we can improve all the anterior zone with dental veneers. We take the impression of the provisional, and now in the digital workflow, we can compare the initial impression with the one with the final crown 4 months. And we can notice if we lose some tissue, not only soft tissue, we'll notice with the CVCT, we lose some bone tissue around our surgery. And it's important to mention that in this case, we don't use any kind of graft, just the gap between the shield and the dental implant. And this is the final crown. We can expect this variation in the junctional epithelium, concave, the ideal for soft tissue ingrowth, straight when we have compromise of the tissue, but we can also go for convex when we have a very thin tissue peel type after 4 months. This is the final crowns. So this is the final result. You can notice the position of the gingival margin, very strong margin. Remember how the patient come to our office with a lot of inflammation. You can notice also the subcritical contour and also the critical contour 1 millimeter below the gingival margin. This is the final crown. And also Wenhcke the anterior. Sorry, this is the video with the final result. With no graft, initial situation, 4 months later with the final result. We can notice a small scar in the number 9. Occlusal view, we preserved the bone. A contralateral view, I like very much this kind of picture because we can compare with the other contralateral tool. Platform switching, straight abutment. And also we can notice the CVCT, how we preserve the bone, especially in the buccal area and the cervical area, leaving a partial root fragment in this side. And we expect to a bone ingrowth between the shield and the implant. But the most important view is this occlusal view. You can notice how we preserve without graft all the buccal area. This is the shield. You can notice the shield and the dental implant and how we leave a gap between the shield and the dental implant. And with no graft, we preserve the cortical aspect. So this is a photography, and we expect bone ingrowth above the superficial part of the implant. And maybe you are thinking how the bone can ingrow there because the abutment is polished. But remember, in the history, when Wenhcke discovers osseointegration, it was polished titanium that was attached to the chambers of the rabbit. So if you don't move it, if you have a good connection, maybe we can expect bone ingrowth above the surface of the dental implant. So these are the 3 phases described by Dr. Gomez Meda. And remember that we nowadays don't expect bone loss like in the past. We expect just bone remodeling or maybe just maintaining the same quantity of bone. So I want to show you this research that we present in the EIO. It's 4 groups. In the group A, we use submerged cover screws with 1-time abutment. In the group B, combined submerged screws with bone grafting. Group C, with a transgingival healing. It was a group with the healing exposed to the oral cavity. Group D used transgingival and healing screw with suture, but under bone grafting. All the groups were very good. You can notice this picture of the group A, and you can notice that even we don't use bone graft here, we submerge, we have bone surrounding the abutment. But the better goes with the B. It has the less bone remodeling, and we don't have any kind of bone loss in any 4 of the groups. So we published this in the clinical oral implant research. So let's talk about partial extraction therapy. This is a group that mentioned 3 types of techniques. One is the socket shield technique that we already mentioned. The first one is the root submergence technique. We lift all the root under the pontic, and the one in the middle is pontic shield. We reduce the fragment of the root in just the buccal aspect and under a pontic. This is the pontic shield technique. So I want to show you what option do we have when we're going to replace the four maxillary incisors. Option number one, insert the implants in the center. We have a better socket. We can go for a standard there. This is option number one. Insert the dental implants in the center and use the other ones as a cantilever. This is a patient that come to our office with trauma. Then we go for immediate provisionalization, and this is the final result. This is option number one, 2 implants in the central incisors. So this kind of treatment, it's very tricky for our dental technicians because we need to do a cantilever in the lateral aspect. But you can notice a very beautiful result. The buccal aspect was preserved, not only bone, also soft tissue, and only doing the socket shield technique and bone graft. We don't use soft tissue graft in this technique. We can use it, but in this patient, we don't use soft tissue graft. This is the final result. And remember, be under the gingival margin at least 4, even 5 millimeters, so we can create a very good emergence profile. So option number 2, use 2 dental implants in the lateral positions. Option number 3, insert 4 implants, as you can show here. Try to be a traumatic or dental extraction. We don't have this incisor, this lateral incisor, so we do the ridge split technique. And we're going to insert the 4 implants. This is the immediate, this is the final. Option number 4 is intercalate implants, lateral and central incisor. This is the case that I'm going to present to you. This is the initial situation. The patient has a very acute, big infection with a lot of pain. You can notice in this area, in the 4 maxillary incisors, especially in number 8. So the first thing that we need to do is to convert this acute infection in chronic infection with systemic antibiotherapy. After 1 week, the patient comes better with no pain and with a lot of reduce of the edema. But we still have papilla there, but we know that because of the infection, we lose a lot of bone. So this is not very easy to do because we need to recreate of this bone loss that we lost with the previous infection. So always try to sound with a perio-proof. Let's go to the surgery. We can notice that the number 8 has the biggest problem. Maybe you can think, but 9 is okay, but you can notice the fracture of the crown fracture, a lot of apicoectomies, a lot of history with this patient. So we need to replace the 4 maxillary. We decide not to go with the immediate implant in number 8 because of the huge infection, because of the problems. Only in the other ones, you can notice the crown fracture in number 10, and we're gonna use dental implants in number 7 and in number 9, in number 1.2 or number 2.1, and try standard so we can go for a cantilever. In digital planning, we can also insert our implant. We know the final position, our screw or access hole screw, and also the provisional. Remember that we need to be at least 1.5 between the implant and a natural tooth. We're gonna use pontic shield, not root submergence. We're gonna leave just fragment of the root in the number 10. And we're gonna use socket shield in number 7 and number 9. We're gonna do preservation of the socket, and in number 9, socket shield, and try to leave at least 2 millimeters of gap. This is the initial situation. With the provisionalization, we need to be with, or to create the final gingival margin according to the aesthetic zone. So we can do in our software all the position that we need to be at the final stage. Remember that we're gonna extract, we're gonna lose some bone. So that planification has to go in our immediate provisionalization. So this is the final position after the surgery that we expect. And that's how we plan our provisionalization. Improving the gingival contours. This is the surgery. We remove the crowns. Remember that we're gonna do the socket shield technique in number 9. We need to be at least at the bone level margin when we do the Pontic shield technique. With the digital workflow, we can individualize our teeth. So we know what we're gonna extract, so we know how we can plan the dental extraction of the Pontic shield. We decide to do a socket shield guide. In this case, you can see this guide. When we design a socket shield guide, we need to be at least anterior to the apical part because we're gonna section in this area, and then insert our implant in the palatal aspect, leaving a gap between the shield and the implant. So we need 2 guides with this case. This is the socket shield guide, a little buccal aspect, removing the palatal fragment. This is the occlusal view. And then we're gonna section mesial and distal to remove the palatal fragment of the root. Try to remove all the granuloma tissue, all the infection, clean with saline solution. Then insert our implants, guiding surgery in number 9 and in number 7. And the bone that we collect with the drilling bars, autologous, is pure gold, is the gold standard for regeneration. And we're gonna use between the shield and the implant, and also in the Pontic shields. We use a long implants because of the dental infection. We torque at 30 newtons. This is the occlusal view. And this is the plan, remember, socket shield in the dental implants. In number 8, we need to clean, we need to remove everything, so it's gonna be a rich preservation. And in number 10, Pontic shield. We pack the bone with a peri-approved, so we don't touch the implant. It's very clean, it's very thin. It's easy to push the bone in that manner. Then we use one-time abutment connect, 4 millimeters below the gingival margin, the dental implant, and the one-time abutment 2 millimeters below the gingival margin and 1 millimeter above the bone. And look at the temporary restoration. It's only possible with guide implant surgery. It's very parallel. Then also do soft tissue grafting number 8. And after 3 months, we have this. We don't have enough papilla. We need to do another kind of provisionalization, but we have soft tissue, we have bone. So it's easy to manage this provisionalization because we preserve biology since the beginning at the initial surgery. We have now dental facial scanners, and it will improve our communication with our lab. It's easy to show the patient what we are doing. It's easy to show our dental technician what we need to improve with the papilla. And these are the modifications that we do in the software to gain papillae and also to improve the gingival contour. This is after provisionalization. We already sectioned the tooth, the structure. We don't have a complete bridge. Now we have a cantilever, and this is 1 month after the second provisionalization. You can notice better contours. You can notice better results. Remember that when we use the one-time abutment concept, we don't notice that connective tissue. We only have junctional epithelium and gingival margin because the connective tissue is attached to the abutment, and we can see in the occlusal aspect. This is the final result. You can notice a buccal papillae and a palatal papillae, and between them, the call that is very difficult to obtain when we go for dental implants. Then we can scan for the final provisionalization. Nowadays, scanners are really, really fast and very precise. This is the position. Then we also scan the provisionalization, not only the tissues, we also scan so we can reproduce in the dental software for the final crowns. This is our final result. This is the initial situation and the final situation. In digital workflow, we need to print a 3D printed model. We use another kind of dental aesthetic abutments. One-time concept, this is the final result. Control, initial, doing the surgery, socket shield, pontic shield, bone graft. Remember that we need to do bone and CT graft to compensate all the loss that we're going to expect in number 8, because we're going to compare number 8 and number 9. The critical contour, the subcritical contour, and the connective tissue that we can see. Now, let's see a movie of ET. This is the final result. It's a final crowns with a cantilever. Remember the huge infection that we have at the beginning in number 1.1 or number 8. This is a control appointment. And you can see this healthy tissues. Remember, we can't see here the connective tissue, just the junctional epithelium and the sulcular epithelium. But look at the buccal aspect. One-time abutment concept. This is a lateral view, the call, contralateral view. And this is a post-operative CVCT. Let's see the initial CVCT, huge infection, crown fractures. And you can notice the shield in number 7 and number 9. And also look at the number 8, how we have a soft tissue graft, how we compensate all the loss of the huge infection, and the pontic shield in number 10. We'll go faster because of time. I want to show you this case. So this is one of my favorite cases. This is not a partial root retention, but it's a biphosphonate case, osteonecrosis by medication, stage 3. You can notice in this panoramic view that we have a very huge osteonecrosis affecting the dental nerve. So we manage conservative, we regenerate bone with patient, with a lot of treatment, with a lot of time. Then we extract the second molar that was affected by the osteonecrosis. And with time, the bone get healing. It has some kind of, this is the final result with the final crowns. Let me show you the treatment. We need a wide implant in the posterior area. Guide surgery, initial situation after the regeneration of the osteonecrosis. This is immediate provisionalization the same day. With 3D printing, we can deliver the crowns after 2 hours of the digital impression. When we are doing the soft tissue and bone graft, our dental technician can start doing the crowns, and this is the final crowns. So we use a wide implant. I'm gonna be faster because of time. After osteonecrosis, we can torque when we have very good results. Same concept that the anterior thumb, it's better to go concave, so we'll have soft tissue in ground around our implants. This is the immediate result after the surgery. Remember, osteonecrosis stage 3, provisionalization, be below 4 or 5 millimeters below the gingival margin, trying to do a very good emergence profile. Remember that the second molars are very difficult to manage because of the submandibular canal. We need a short implant. But I love this dental tomography picture, 2023, huge osteonecrosis, very poor bone, the dental nerve affected with paresthesia, and how we are today, 2026, with not only recovering for osteonecrosis, we also reconstruct the area and the patient is now using function in that area. This is not a good picture, but I love how you can notice the connective tissue and how we still have keratinized tissue that was lost by the osteonecrosis, but with patient we can recreate everything. This is a guide of osteonecrosis medication, but it's in Spanish. If you want, you can translate it and download. I will try to talk about I just want to show you this kind of treatments. Okay, I don't. This is my first superosteal plate. This is the control over denture in the lower jaw and how we can change life in our patients. This is his superosteal plates, another kind of treatments when we have a very atrophic bone. So you can notice that we can plan. It's another technique. We can use zygomatic, we can use pterygoid implants, but we can also use custom superosteal CAD/CAM implants. It's especially when we have a very atrophic bone. This is the occlusal view, the frontal view, and with implant technology, we can take the impression after the surgery and we can deliver our provisional restoration the same day or maybe the next day. Initial provisionalization, 3D printing, very strong results. Another case of failed implants of a maxilla overdenture. And you can notice the 1 year follow-up in the lower area. So my conclusion for this lecture is immediate implants works very well. We don't need to follow the rules. Biological driving implant placement, not only prosthetical driving implant, not only functional implants. We are in a new area that we need to take advantage of our digital technology, and we need to go for biological driving implant placement. Proper selection of surgical techniques. We need to learn a lot of different techniques and do what works best in our hands. And also remember that technology is an ally for our treatment planning and execution. So thank you so much for the invitation. It's always a great pleasure to be with you. And I hope you like my presentation.
Thank you, Dr. Bruno. We will wait for questions now. Okay, the first question is when transitioning from a freehand approach to a fully guided digital workflow, how do you manage the discrepancy between the virtual planning of the implant's position and the real-time physical resistance of the retained root to ensure the biological width isn't compromised?
That's a beautiful question. It's really, really a very difficult to manage if you go for freehand. If you want to have better results, it's always a better place or better way to go for guide surgery. So maybe you can go with freehand and try to measure with a probe, trying to um, use a prosthetic guide. Also, if you are not in the ideal space or you're not in the ideal location, you can use probe to see the direction of your implant and the depth of your implant, and you can change most of the time, but you need to do another drilling, not the 100% of the steps, but if you do different drilling, you need to start from the first initial burr and always try to manage because of the space is going sometimes very difficult when you're doing immediate because of the air and the space in the buccal aspect. Always double check, but it's more difficult to go for freehand. And as this picture says, learn the technique first, growth comes with time. So with time, you're gonna be more, we're gonna be more easy to go for freehand surgery. But at the beginning, it's very difficult because maybe it's gonna be too much buccal or too much depth, or maybe it's not the necessary depth of the implant. But you have to try and practice as all the techniques in dental field. Thanks
Thanks,
for the question.
thanks a lot, Dr. Bruno. We have another question. In cases of socket shield partial extraction therapy, how do you clinically monitor the health of the retained root fragment over the long term? And what are your specific rescue protocols if the buccal plate begins to undergo late stage resorption despite the presence of the root fragment?
That's a beautiful question. The socket shield technique can have some problems in the second stage or the future. One is the internal exposure, and it's very easy just to reduce with the board. And also, if you expect some kind of resorption of the root, maybe it's going to be bone below this resorption. So it's not a problem. The only thing that you have to individualize is that when you are doing the socket shield technique and you have a mobile fragment, it's better to remove because it will not have any kind of good prognosis if you leave there. Just leave the partial fragment where it's very strong attached to the bone. If you have a mobile fragment, it's better to remove after continue the treatment. And it doesn't matter if you remove because you're gonna manage like you're doing immediate implants with another technique with guide bone regeneration or socket preservation, soft tissue or bone tissue graft.
Thanks a lot, Dr. Bruno. Dear Dr. Bruno Wenhcke, on behalf of the IADS SCORE webinars team, we would like to extend our sincere gratitude for your exceptional session on partial root retention and digital implantology. Your presentation masterfully bridged biological concepts with modern digital precision, offering our global community a truly cutting-edge perspective. We are deeply appreciative of the time and high-level expertise you shared with us today. We look forward to the possibility of collaborating with you again in future. With best regards, IADS Core Webinars team. Thanks a lot, Dr. Pro.
Thank you so much, Alan. Thank you all. Hope to see you soon.
Thank you, Dr.